are the general practitioner, know when to pass that patient off. Don't keep trying to treat it in-house and going, well, let's see if another round of antibiotics is going to help this patient. Send that one off. If it is beyond your ability to correct it, send it off. All right. Lower airway disease in 8 minutes or less. All right, so we've alluded to some of these things. COPD, we've got to talk about pulmonary hypertension in terms of lung disease. We touched on chronic bronchitis. Got to talk about our respiratory parenchymal diseases. We won't get to edema formation. I think I'm going to do that one as a PowerPoint. We've already talked about edema formation way back when you guys were first years. So we don't need to sit in class and talk about it again. But you need to know that mechanism, because now you're in clinics, we're going to start saying, oh, how your patients develop edema? You got to know those 4 major mechanisms. All right. So bronchitis. It's relatively common. You're going to see some patients that have bronchitis. You're going to see varying degrees of bronchitis. Some of them may be allergic bronchitis. Some of them may be secondary to something infectious or something environmental. So we go through the diagnostic process. What we get from these patients is, if this is bad and chronic, you get chronic pulmonary wheezes. Some of these patients will actually develop pulmonary crackles, harsh pulmonary crackles, the more severe this condition gets. So we go through the history. You know, is there a smoker in the house? Have you pulled up the carpeting? Did you have air fresheners, new sprays, new carpet fresh? Old furniture, maybe the owner went to the thrift store and they found this lovely old chair that really needs to be reupholstered, but they brought it in their house and put it in their bedroom, and the dog sleeps on it, and the dog coughs every night. You go, okay, well, does the dog cough when he's away from the chair? No, it's only at night when he's sleeping. It's the chair. Get rid of the chair. And that was probably one of my most recent chronic bronchitis patients. So there's usually some sort of clinical history in the environment that leads you to go, maybe this is a respiratory irritant, I can't get it out today, and I need to figure out what that irritant is and get it out of the house. Owner says smoke, tell them to smoke outside, and tell them to change their clothes when they come in, because they're going to carry it on their clothes when they come back in. Clients that burn wood outside, don't let the dog hang out outside while you're burning wood. Get a HEPA filter. All of those environmental changes can help these patients. Pull up the carpeting if you've got dust mites. The downside is that with chronic bronchitis, we get secondary disease that's lower in the airway. So we can get what we call bronchiectasis, where we get fibrosis of our airways and they're kind of frozen open. So here, under the pink arrows, you see we have a nice normal airway and it has nice normal tapering. Here we have a dilated bronchus, and then it tapers sharply. So this is a patient that has bronchiectasis. This airway is fixed, open. It's no longer elastic and opening and closing as our patient is breathing. Well, not closing, but kind of moving as our patient is breathing. It's fixed open. So that means that you have fibrosis and you're not going to have normal cells, which means your mucociliary apparatus is going to be affected, and we're going to get more mucus accumulation in the lower airway and less appropriate air movement. We can get bronchomalacia. So we have our nice normal open bronchus. This one is collapsed and probably on expiration based upon what we're seeing. So if my lower airways are collapsing as my patient is expiring, that's actually going to cause air trapping in the alveoli, and then it's going to cause the alveoli to stretch. And then we lead to that COPD type of condition where now you're developing Ebola in the area of your alveoli. So instead of having nice, tiny little alveoli, you're just getting a big pocket of air that's not very effective in moving oxygen into the blood. Yes? That was a discussion for another day. Tell you what, I'll go back to that when we're done. Pulmonary artery hypertension, you think, oh wait, this is a cardiac something. But really this is an oxygenation issue in some of our patients. So if you've seen the people that walk around with the little oxygen tanks, now they have like nice little backpacks or nice little strollers for their oxygen. Those people probably have COPD and they have pulmonary hypertension. Now, oxygen is one of the best ways of managing pulmonary hypertension because it allows for the vessels to relax going to the pulmonary arteries. So it's a pulmonary artery dilator. Oxygen, easy, cheap, simple. We do have some drugs for that nowadays. But what we recognize in our patients is they can have pulmonary artery hypertension from having heartworm disease. Maybe they had a heartworm embolus. But we can also see it from chronic bronchitis. So if that pulmonary artery has enlarged, then what we get is contraction of that pulmonary artery, which means the blood is not flowing out of the heart, which means this is going to lead to heart disease. All right, so other causes for pulmonary hypertension, you can have a pulmonary thromboembolus from some other inflammatory process. Less commonly, we can see it with mitral valve disease, so we can see some right heart disease, even though we have a left-sided heart issue. It's less common, but it does occur. Cor pulmonale is a very acute formation of pulmonary hypertension, so it can be from any one of these particular conditions. And the little blue pill is a medical way that we can manage it. So that's what the little blue pill was originally designed for. And then the pharmaceutical company said, hey, it's got better function that we can charge a lot more money for. So the interesting thing is we have two formulations of sildenafil, which is our drug name, on the market. One is marketed for pulmonary hypertension. The other one is marketed for erectile dysfunction. The one for erectile dysfunction costs like 10 times as much as the one for pulmonary hypertension, but it's the same drug. So you gotta know which one to ask for if you're gonna get this for your patients. All right, let's pick up on asthma tomorrow.